Well, good afternoon or good evening, good morning, wherever you are in SADS Facebook Live land. Welcome to podcast or Facebook Live number 27. We've been together since February or March, and delighted to have you return and looking forward to what questions you have as you are joining us. I'm delighted to be joined by two really special people. Brynn Dechert is a nurse practitioner at University of Michigan, and she joins us, as well as my own cardiovascular genetic counselor, Katie Agray from here at Mayo Clinic. So welcome to the program, Brynn and Katie. Thanks for joining us.
Thank you. Happy to be here.
Before we get started with talking about the critical roles of nursing on genetic heart disease teams and genetic counseling on our teams that have been assembled for, some people call them genetic heart rhythm clinics like we do, others talk about them as the Inherited Arrhythmias Syndrome program. Whatever name you two and the professions that you two represent are absolutely vital to the mission of taking care of SADS families well. So thank you for what you do. Before we get going, just a reminder, we do have this thing called COVID-19 pandemic. We are approaching 25 million cases worldwide. Tragically, over 800,000 deaths in the United States. We have 5.9 million cases and over 180,000 deaths attributed to COVID-19. We talked about a silver lining last week as maybe we're flattening the curve again compared to the first peak earlier in March and April. We hit a high of 77,000 cases a day on July 16th, and yesterday there were 46,000 cases. So maybe we're starting to see some good news. So a reminder, everybody out there, do what works. Put on the mask, just do it. Stay apart, 6 feet distancing when you can, wash your hands a lot. These things actually work. And if you want to get back to normalness in your communities, just do it. But we're going to do something really important now, not COVID-19 related, but related to our families with genetic heart rhythm and heart muscle conditions that predispose to sudden death, and talk about the unsung heroes, the really important members of the team, our nurses and our genetic counselors. And so, Brynn, you represent the nurses on these genetic heart rhythm teams, and you're a nurse practitioner. Not only is Brynn a nurse practitioner, she's been a member of the SADS Foundation board for the last 6 years. And she also was the first allied health professional to be on the executive committee of the Pediatric and Adult Congenital EP, or Electrophysiology Society, also known as PACES. And SADS Foundation has enjoyed a very rich relationship with that professional community of PACES. So, Brynn, you come with a wealth of background and experience. Give the SADS community a little thumbnail sketch of who is Brynn Dechert anyway.
Well, like Dr. Ackerman said, I'm a nurse practitioner at University of Michigan, and it's definitely a rewarding career. I think one of the biggest things that I can offer a program is a very close relationship with the families, as well as education. I manage patients, I write prescriptions, but I really am the first person that a patient will call if they have a question. I'm the first person that will give a patient a hug if they need it. Obviously, COVID is a little bit of a different time, but I feel like I can offer a close relationship and education that for the whole family. I work very closely with the physicians I work with. I work very closely with genetic counselors that are on our team as well. And together we make a rich team. So I was joking with one of the physicians I work with that I'm the heart of the program and they're the head of the program. So I think it's definitely a give and take relationship. And having a team like this really does allow us to provide comprehensive care to our patients. And I work closely with and collaborate with other institutions, Dr. Ackerman included. And so it's really a very nice relationship, and I very much enjoy my work on an everyday basis. So usually I see people in clinic. I answer a lot of phone calls. I actually check ICDs and pacemakers and things like that. So you, as a patient, you would get to know a nurse or a nurse practitioner very well.
Great. Well, thanks, Brynn. And you are the heart of a program, heart and soul.
Thank you.
You mentioned genetic counselor, and certainly in Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, I'm spoiled because I have a genetic counselor, and she is center screen, Katie Agray. So, Katie, you talk about the profession of genetic counseling a little bit, and cardiovascular genetic counselors. Tell us a little bit of how you got from there to here.
Yeah, absolutely. So genetic counseling is a relatively new profession. It's been around for 50 to 60 years at this point in time. But genetic counselors are health professionals who have training both in genetics and biochemistry, but also in psychology. And our job is really to help bridge the gap between really complex, overwhelming genetic information and the families and patients that we care for every day. Cardiovascular genetics is a whole new and very exciting area. And so I have background in general genetics and practice in general genetics for about 4 years before I had the opportunity to really focus in cardiology genetics. But I would echo Brynn's thoughts that, it is a really rewarding, profession. It's such, it's such a wonderful thing to be able to work with these patients and families every day and see their resiliency and their hope and their determination.
And Katie, I know you have a society. This is the National Genetic Counselor Society, and it has a special emphasis cardiovascular interest group, which I believe you're the president of.
Yes, I am one of the chairs through the end of this year of the National Society of Genetic Counselor Cardiovascular Special Interest Group. So we have about 300 members and genetic counselors scattered across the world, but many of them in the United States who have interest or focus in cardiac genetics. And that number keeps growing every year, which is quite exciting.
So for those of us who joined us out there, let me know who you are, typing your questions in the comments, and if they're relevant to a nursing question that I can direct towards Brynn, or a genetic testing, genetic counseling question that I can direct towards Katie, that'd be great. I'd like to see if some of my Facebook Live friends are connected today. I think I have it connected right, but usually some of you have clicked on and said hello already from Dublin, Ireland, and the other places throughout the world. So I hope we are all connected correctly. One of our SADS Foundation gurus, Erin, is on a well-deserved vacation, and she normally does this. And so right now, guess who's doing it is my boss, the CEO of the SADS Foundation, Alice Laura, and she welcomes you and thank you for joining us. Brynn, I'm curious, these last 9 months, 8 months since this thing called COVID-19 rocked our world and affected our country and our patients, has there been like one big item that has been consuming more of your time as a nurse with questions and concerns from our SADS families? And what's the one big thing that you've been more busy with these 7 months than previous years?
Yeah, I mean, it's turned into we had a slowdown for a little bit in March when we were concerned about resources and helping our adult colleagues take care of these sick patients that were in the adult hospital. We didn't have a lot of COVID in pediatrics, at least in our institution, but again, we needed to be there to support our adult colleagues, and we were all on the line to cross over to adults if that was necessary. What we're dealing with now is getting back to business, and we're trying to get back to business as safely as possible. So I spend a lot of my day scheduling patients and reassuring patients that we have done everything that has been recommended, which Dr. Ackerman talked about. All of our patients are screened with questions before they come in the building. Everyone wears a mask. And in addition, our procedure patients all get COVID testing prior to procedures. So I spend a lot of my time scheduling patients and trying to work with them very closely to make you understand that we are safe and we're doing everything that we can from a safety standpoint, but we are back to business and we are in the business of helping our patients. We are doing procedures. We are seeing patients in clinic. And I think one of the silver linings of COVID will be our virtual presence. We had started seeing patients virtually prior to COVID a little bit, but when COVID happened, we really exploded into our virtual presence. And what we realize is patients, like patients with long QT or channelopathy patients, many times we can do our visits virtually. Dr. Ackerman, obviously, it can be a distance to travel to see him. He's a world expert. So if you live in Michigan, it could be challenging to get to various places. Michigan is a very big state. So we were starting to see more patients virtually. So I'm spending a lot of time with the virtual presence with our families. I can get EKGs locally, have them sent to me. We can review them and also talk like this over a camera with our families, which has really helped. It obviously does not take the place of an entire clinic visit, but it really helped us get through a tough time in March and April where we were very concerned about the safety of patients coming in and out of the building. And so we really built this virtual presence. So even beyond COVID, we're starting to flatten out, but we're going to probably continue doing a lot of our visits virtually, which families do appreciate. We can do them after hours. You're not stuck between the kind of 8 and 4 time frame. I've been seeing patients after their school day, after their work day, things like that. So I think one of the silver linings will be our connectivity. And I think SADS is doing a wonderful job with this. I mean, like Dr. Ackerman said, we're on number 27 here for these live Facebook events, and that's really connected our patients. So I think I'm spending a lot of my time, I feel like, scheduling and rescheduling and making sure people understand that they are safe, and coming into the hospital for the care you need is definitely a safe thing to do. And we will continue to be safe. We're now wearing eye goggles and masks. So it's funny. We kind of joke like, oh, you can't really see my face, things like that. But it's also exciting to talk to families about what they're going through, or your kids going back to school, virtual. I mean, there's a lot of questions out there. So I have a great time actually kind of connecting with patients and asking those questions.
Yeah, I think this whole video consult and telemedicine is incredibly exciting, and it probably finally served as the stimulation to make sure we figure out how to do this. And so Katie and I were in this phase now where we can go and see one patient across the hall with masks on, and then my next appointment is a Zoom video consult with masks off. Right. And in some ways, the video consult is more connected and special than the masked on way. But we'll be doing both. Whatever is the best interest of the patient, as we say here at Mayo, is the only interest to be considered. And sometimes the best interest is to do it virtually by video, and sometimes it's to get on campus. So I think this duality of our practices is going to be quite interesting to see that develop. Katie, I see that we have an emerging future genetic counselor on board, Ashley. Mm-hmm. So Ashley, welcome from Houston. It's a great career path. I'm sure Katie will agree. But Katie, during this time I know you've been doing video consults as well. For those who don't know, and for many programs that don't even have a genetic counselor, which is a whole nother topic, what are the critical elements of genetic counseling mm-hmm. that programs need to be doing if they're going to be taking care of patients and families with genetic heart diseases like long QT syndrome?
Mm-hmm. I think it's really important to have a genetic counselor, someone with genetics expertise on the team, because it's so critical in providing the best possible care for our patients. And genetic testing can really be quite impactful on a patient's management and care. And so, a lot of my everyday work is seeing patients, assessing the need for genetic testing, of course, talking with them about pros, cons, benefits, how is it actually going to impact someone's care, and of course their family as well, and helping them come to a decision on whether that's the right choice for them. And then of course, there's a lot of follow-up on genetic testing results, which can be very, very complex in a lot of situations. And so helping patients understand what is important for them to understand, how might they communicate this to family members, how might communicate this information to children, since children are often our patients, and it can be challenging to figure out what is the best time to have those conversations about whether a child may be at risk for a particular condition. And I think that's all things that genetic counselors can help with and benefit, not only the patient and family, but the whole multidisciplinary team.
Yeah, and Katie, this is a great question from Jesse for both you and Brynn, and it goes along the lines of having a particular genetic heart condition, in this case CPVT, and her mother and brother should be tested. The doctors have said, doctors were right, but they don't do it. They ignore it. And this patient has done her best to try to make it clear that it's important. And because her brother has a son, and you know this story over and over, we hear it all the time. She said, what advice can we give to help convince them to do the genetic test? So when you encounter this, Katie and Brynn, in the relationships that you develop after the visit, which are oftentimes special and deeper than what the physician connection may be, what things are you guys finding that helps work to get the families who really, really do need to be tested? Mm-hmm. Katie, how about you first, and then Brynn?
Yeah, I feel like I encounter this just about every day in my conversations with patients of, this relationship to me, my brother, my uncle, my mother doesn't want to do genetic testing. And there's often various reasons for that. A lot of them stem back to concern about genetic discrimination. Some of them also stem back to fear about, what does this mean for me? I also worry about, potential misinformation in some situations of patients not understanding that, yes, you are healthy, but that doesn't mean you don't have the same condition. And so, of course, oftentimes, you can't convince your family members to go out and do something. You can only control yourself in most situations. But I do think it's important to emphasize, at least have that conversation with a genetic counselor. I'm not going to go force anyone to do the test, but at least to make sure they have all the information out there to make the best choice for themselves. And so that we can clear up any information about what is or isn't a part of the diagnosis.
I agree with Katie. I think you can't take someone and tie them down and get the genetic testing done. And so the worry and the stress that you may be putting yourself through, really trying to convince a family, may take a toll on you. So do your best, give them the advice and the scientific evidence-based information like Katie was describing and Dr. Ackerman can provide as well. But again, you're going to have to take a step back, let them think about it. Sometimes just taking some time, they have the information, and just take a step back and let them take care of it. I don't feel bad. Well, of course you don't, but it's something that's still important for you and your child. And so I think you can only do so much. You can present the information in a factual way, but I would take yourself out of that equation. I know you're obviously would care about your family, but you can't put the stress on yourself. It is not your responsibility to force someone else to do it. And I think Katie and Dr. Ackerman, as well as myself, would always be willing to talk to that family member if they were willing to contact us or they had questions. We could help answer those. But I think you're doing the right thing by having these discussions. But I think it's the ball's in their court at this point.
And I would just add, there's kind of two different principles: is duty to warn, which is, what you're doing and letting your family members know about this, but it's also right to know and right to decide. So I think that's really an important part that Brynn brought up, is that at the end of the day, that is their choice. But I think your duty is to make sure that they're aware of this and know what resources and options there are.
Yeah, I think Jesse asking that is so good, that for the duty to warn. And I know one of the things that Katie and I have done in our program here at Mayo is we try to take the work off of the patient, so that we'll have a section in the note called family screening recommendations, where I'll outline a paragraph of exactly which family members need to do what next and the why. And then I tell the patient, if you're comfortable, just give them your note. Give them this note, highlight this section, you've done your duty. Mm-hmm. And then, or give them the number to Katie and say, just say, reach out to the genetic counselor and we'll talk to you and walk you through this. And then you can decide on your own, but please reach out. And whether you reach out or not, I don't have to know as the patient, but they've done their due diligence. And I would only emphasize for Jesse, I'm so glad you want to do this, because the tragedies that we see in our program are few and far between, thankfully. after we diagnose long QT or CPVT or anything and get a treatment program in place, we almost never have a tragedy. The one exception have been where there was knowledge of genetic disease in family, there was ability to cascade test the relatives, and then we get a call a year later that cousin so-and-so died suddenly because there was not that family part never chose or never knew about the availability that the family curse had been genetically sleuthed and solved years ago, and didn't get that reach out. So do your part, and let Katie and as a genetic counselor, let Brynn as a nurse practitioner, loop in the other members of the team to give you more advice on how to do that. But you can lead them to the water. You
can't make them drink.
Can't make them drink. Brynn, I'm wondering if, as we're now approaching back to school, and some are, some aren't, have you been receiving a higher volume of calls from your families, and what questions are they asking you, and what answers are you providing during this little bit crazy time?
Yeah. So, families are all over. Every state is doing things different. Every county, every district are doing things a little bit different. A lot of places are doing hybrids or virtual or in school. And families are nervous about going back. They are excited. The kids and the families are excited to have their kids go back. I have a 12-year-old and 10-year-old, and it's been a long time since they've been in school, and they're not going back. They're going back virtually. But I know that it's probably it's safe for them to be at home. I think we could make it safe at school too. We just have to see how things roll out. But families are concerned about about their likelihood of getting sick. And so, Dr. Ackerman, you can probably expound on this as well. But if you have a channelopathy like long QT or CPVT, you're not at more risk for getting it. And so that's what I tell families all the time. If you do what Dr. Ackerman talked about in the beginning, which is a mask and washing your hands and staying 6 feet apart, which can be challenging in school, I think that the likelihood of you contracting it is lower. But I don't think that you're at any more greater risk for getting COVID just because you have CPVT or long QT. And that's something that you have to remember. In Ann Arbor, the college kids are moving back to campus. University of Michigan is live, and they're all coming back, which does put a little anxiety in the rest of the community, just knowing that all these people from all over the world are coming back to our tiny little town. And so I think that just, again, doing your best to stay safe, do the safe practices like Dr. Ackerman talked about. But we do get a lot of calls like, am I at more risk? Do I need to really, lock myself down? And following the recommendations of your state and your city and as well as medical professionals is the best advice that I can give.
That's great, Brynn. And be interesting. I have heard that you're not playing football though.
No. Dr. Ackerman's really trying to help that, right?
That's a whole other topic of conversation, but one of my life highlights that Brynn knows, and there might be a video out there somewhere in SADS Foundation land, I did kick a field goal.
That's correct.
University of Michigan Stadium because of Brynn and a SADS Foundation thing that we did there, thanks to Brynn and all of her organization. So that's actually on my life highlight reel. So that was a very special moment. Brynn, Katie, I know one of the things that has come about in your world and kind of rocks the world of our patients, and one is asking it more or less in the question of, they get a genetic test result and it tells them it's a variant of uncertain significance. And now they're sort of saying, well, do I have this or do I not have this? What does this mean? My doctor didn't even know I had it, or my doctor said, I definitely have long QT, but now I've got a variant of uncertain significance in this supposed gene. I imagine this VUS issue and the ambiguity surrounding it occupies a lot of your time and confuses our patients tremendously. what steps do you walk them through to help them understand what that result means or doesn't mean?
Yeah, I think that's a great question. It's something that comes up very frequently. And, oftentimes the conversation that I'll have with my patients before they do testing is about the possibility and usually the high likelihood that we're going to get an uncertain result, especially now that we have the ability to test so many more genes. Variants of uncertain significance just go back to the fact that every human is very unique and has different genetic changes, and not all of which we understand at this point in time. And so, when we get these uncertain results, I think it's really important for someone who has familiarity with genetics and the particular condition that we're thinking about to really evaluate this, to say, is this something we're suspicious of, or does this seem more likely to be benign and harmless? And so I think it's important to do that double check. The laboratories give us the classification, but it's important to verify that as well. And also to correlate it with what we know about the patient's medical history, because obviously the providers taking care of the patient have that unique perspective that the lab doesn't always get, and at least in as much detail. But it's a lot of times having that conversation with the patient about what do we know at this point in time? What types of actions can we take to potentially learn more about this? But it's also being cautious, because we need to avoid labeling other family members as having something if we don't have as much certainty as we want to have. And so more and more we're getting reclassifications over time, and there's been some data to show that about 90% of variants will eventually be reclassified as benign. That is more in cancer genetics, and hopefully we'll get some more data about that in cardiology genetics. But I think it's important just to really set expectations with patients that this is a possibility, but then also making sure that we're doing our due diligence as clinicians to make as much effort as we can to better understand what's going on for the patient.
I think that's great. And I have to say that I think your ears and my ears must have been burning or twitching or whatever that saying is, because I posed the question to you before this question came in at 1:45 p.m. Central Standard Time from Brianna. Hi, Brianna. How often, she asked, how often does a VUS get reclassified to either likely benign or likely pathogenic? Do most stay a VUS? So Brianna, that spooks me out a little bit that we were thinking the exact same thing. And Katie, I thought you made a couple of great points, which is first, a VUS named by the genetic test company doesn't have to stay a VUS in your and my practice, in Brynn's practice, that we don't have to wait for a company to formally reclassify it. There's been many VUSs that Katie and I have received from the company that, like that, we've said that's not a VUS. That is a CPVT causative variant, no doubt about it. So that happens to be one gene, the RYR2 gene, where over time, many of those VUSs are just stuck because the analytical tools that the company uses aren't good enough yet. And if Brynn and I, as clinicians, thought the patient really had CPVT, so if Brynn and her team says, I'm taking care of CPVT, I know it's CPVT, no doubt it's CPVT, and then the genetic test comes back as RYR2 VUS, we have so many people out there who say, oh no, we're stuck, it's a VUS, when what they really should be saying is, okay, they called it a VUS, I call it causative. Game, set, and match, test the relatives. And so a VUS, there's a lot of work that we need to do with VUSs, and that's why having the genetic counselor on the team is so critically important for her to come back to Brynn and the physicians on the team to say, you are the diagnosticians. How strongly did you think that the patient had disease X, Y, and Z in the first place? And then that's why it's such a special interaction to go back and forth with the genetic counselor expertise, the nursing expertise, and the phenotype assessment from the clinician. So Brianna, even though I asked it first, thanks for that question. This isn't quite nursing or quite genetic counseling, but it's time sensitive. So I'm going to ask it to you, Brynn, and you and I can deal with this one a little bit. It's from Heather. and she's sharing with us that her son has long QT syndrome and just came back positive for COVID this morning. He came home from college, we'll leave the college unnamed, with symptoms on Wednesday, and he's been quarantined in the basement. Anything to know about treatment? And I guess the first thing I would say to that is, technically your son tested positive for SARS-CoV-2, the virus. That's what we test positive or negative for. And if we have symptoms, and they're important symptoms, then we have COVID-19. That's the name of the disease associated with the virus. That's just for clarification. But maybe, Brynn, can you share the mom a little bit of good news? That this ought to be not a big deal for her son and things like that. When you get a call like this, which you've received and I've received from families, not very often. We don't have very many families who are positive at all, but we have one or two. And when you get a call like this, Brynn, what do you start to share with a mom like Heather and with the patient?
Sure. Obviously, the disease manifestations are different in every patient. But what we've noticed is that healthy people stay healthy even if they have COVID. So I think you have to remember that. I think you're doing the right thing. You are keeping him away from others, spreading the disease to others, because he could run into people who could get sicker, an older person, someone with other types of chronic disease that puts them more at risk, like respiratory disease and things like that. So the good news is your son, is going to be fine. And I think he's going to rest and feel better. But I think the most important thing is the quarantine and the decreasing as much as possible the transmission to others who could become sick. Other than that, there's not a lot of treatment for it. It's just, again, you need to rest and have his mask on, wash his hands, things like that, clean the house. But I think other than that, you're doing the absolute right thing. So I would just, hang on and the 14 days is a long time, but it's an important 14 days. We're learning more about this virus every single day. And I think, Dr. Ackerman, you can jump in here too. 14 days is still the recommendation for quarantining. Sometimes it can travel pretty quickly between people, but sometimes you could even transmit up to 14 days. So I think that's an important thing. But I think he'll be fine, and just continue to watch his symptoms. If you have any concerns that he's getting worse, that's when you would seek medical treatment in a hospital.
I think that's exactly right. And Heather, one of the things we've seen is that when families do exactly what Brynn said, the transmission rate of the virus within that nuclear family is very low. So even though you've got a contagion, whatever, right down the basement, it doesn't get out. There's that really amazing study, I thought, of the two infected hairdressers in that hair salon. And they didn't really even know they had the virus, but they were universally masked, they and their patrons. And I think almost no people getting their hair cut got the virus. So where it's not a surprise in your basement where the virus is, and stay quarantined and just make sure, the 1 point for your son is make sure a well-intentioned physician or nurse practitioner doesn't prescribe your son outpatient hydroxychloroquine or azithromycin. Those two medications are still being prescribed for COVID-19. The efficacy signal is minimal at best, probably vanishingly absent. And those two medicines are absolutely dangerous if you have long QT syndrome. So your son's going to recover without the need of medicine, almost for sure. And if he gets hospitalized and needs medicines, there's some good medicines that can be used. Remdesivir is one that has no QT concern to it. But the odds of him needing to be hospitalized are incredibly low, like Brynn said. We're amazingly, you two, we're almost at the top of the hour. So I'm going to give each of you sort of last nuance or new question or a buzz question that you've been pulsed with in the last week that you think is a question that you find yourself being asked a lot, and here's your answer. So what's sort of the hot button question that you're getting posed, Katie, and what are you sharing with those families?
Yeah, that's a good question. I think one of the recurrent questions and topics that I often talk with my patients about is like direct to consumer testing, ancestry-based testing or health-related testing. And the question of, okay, well, I had this, am I still at risk for long QT syndrome? Am I still at risk? I know I have this family history. Is this the answer? And that's where I think it is really important to bring in a genetic counselor into those conversations, because not all genetic testing is the same. And it's important to realize that you might have had a genetic test, but if we're not looking at that gene in question, we might not be getting the answer. So it's really important to presume that whatever genetic test you had, if it is one of these direct to consumers, that it probably did not test, especially with these SADS related conditions. But I would definitely encourage anyone in that situation to talk to a genetic counselor if there are any concerns, or especially if there is anything that was found with that type of testing.
Great, thanks, Katie. And Brynn, how about for you? What's sort of been the question of the past week that's kind of being pulsed your way?
Yeah, I think, people are, I think the anxiety is kind of coming through for most of our patients in whatever realm, whether it's related to your disease or just the fact that the world is a very weird place right now. And I think we all have to just continue to move forward, to be compliant with your medication. I was going to say that to Heather also. Even if your son has COVID, he needs to continue taking his beta blocker is very important, but also we need to take care of our mental health. So if you're struggling or you are feeling anxious or sad or any of those things, any of your healthcare providers can help you with that, whether or not it has anything to do with your disease. I think we are all in this together. And I think we need to continue to come together and help each other out in these very strange times. And I, I'm always offering myself in these conversations. So I do get a lot of medical questions, but I think lately it's just people wanting to talk, I'm nervous. I don't know what's going to happen. And, I'm right there with you. So I think we're all in this together. And I think we do have to remember that.
Well, that's great. Brynn, I want to thank you. So Brynn is a real friend and a special colleague, and you have been special to many, many families with SADS conditions. And you're very special to us at the SADS Foundation with your role on our board. And Brynn Decker is nurse practitioner at University of Michigan. Say hello to my friends and colleagues there. Thanks for all that you do, and for telling the nursing side as the vital role that the nurses have on our healthcare team. And then Katie, I'm a little bit biased having Katie Agre as our cardiovascular genetics counselor for the Windland Smith Rice Genetic Heart Rhythm Clinic here at Mayo. But I think we still have work to do, don't we, Katie? One, there's not enough of genetic counselors out there, and yet the role of genetic counseling for our families is so important. And sometimes we have to teach our nurses to do it. Sometimes we have to teach the physicians to do it. But it needs to be done, because what you tell them and what you provide is vital information that all of the families deserve to have, whether we have a professional genetic counselor at that medical facility, at that clinic, or not. So tell your community at the National Genetic Counselor Society that we need to double the number in the special emphasis cardiovascular program, and leave the cancer genetic counseling world to come where the action is in cardiology. But thanks, Katie, for joining us, and I really appreciate it. So for all of you out there, this wraps up SADS Facebook Live number 27. This wraps up August. Crazy. August. Crazy. The books. We have a great lineup for you for the month of September. Join us next week, same time, for a back to school session and a SADS Safe School. September is SADS Safe School month, not related to COVID-19, but we'll talk about that as well. And we'll have 2 RNs, Rachel Flores, who is an RN and a SADS mom, as well as Richard Lamphere back by special request. Richard joined me a few months ago now, who is an RN in Atlanta, part of Project SAVE. And we're going to be talking about how to make sure or ensure your school is safe from a SADS condition standpoint, and also take your questions about what are you encountering as you're trying to go back to school, for those of you going back to school. And then you're going to really like the rest of the programming in every Friday in September. So until next week, stay well, everybody. Stay safe, everyone. Put the mask on, except for Heather's son, who already has the virus. The rest of us, let's stay corona-free for as long as we possibly can.
That's right.
Thanks, Brynn. Thanks, Katie.
Thanks, Dr. Ackerman.
Thank you.
Goodbye, everybody.